Bismillah ar-Rahman ar-Rahim. Good morning, both of you, not everybody. We are going to start the morning meeting for pancreatic and biliary cancers. And I'm greatly honored to start with Professor Teresa Macorella. The title of the speech will be What's New in Management of Biliary Tract Cancer? It's a virtual meeting.
Hello, my name is Teresa Macarulla. I'm GI medical oncologist in Vall d'Hebron in Barcelona, and today we will talk about what's new in the treatment of biliary tract cancer. Here are my disclosures. So when we talk about biliary tract cancer, we talk about an heterogeneous group of cancers with different tumor types that include gallbladder, ampullary tumors, extrahepatic cholangiocarcinoma, perihelial cholangiocarcinoma, and intrahepatic cholangiocarcinoma. All of them presented different risk factors, different symptoms and diagnosis, and importantly, different biology and molecular profile. However, all of them have in common the worst or the bad prognosis. The majority of patients are diagnosed in advanced disease, and a majority of patients are only candidates for systemic therapy. Regarding the incidence of these tumors in general the incidence of these tumors are really low, especially in, for example, cholangiocarcinoma. The incidence is around 1 or 2 cases per 100,000 inhabitants. However, there are some zones in the world in which is endemic this tumor, for example, South Korea, Thailand, or China. And in this kind of parts of the world, the etiology of these tumors are different. For example, in Thailand, the etiology is an infection for a fluke. And in China, the reason is related with the infection of virus hepatitis B. In these cases, the biology of those intrahepatic cholangiocarcinoma are completely different from the rest of the world. They presented less targetable alterations and different pathways activated. And then regarding the gallbladder, is even less frequent, between 0.9 or 1.5 cases per 100,000 inhabitants. However, again, in some zones of the world, for example, in Latin America, East Europe, or South Asia, is really an endemic tumor. So it's interesting to see how in some part of the world this is a really frequent tumor, but in other parts of the world, in the majority of the world, it's a low incidence tumor. So how we treat biliary tract cancer? First of all, what it is important when we have the diagnosis of this tumor is to decide if this patient is resectable or not. Ideally, these have to be decided in a multidisciplinary tumor board in which the surgeons and the oncologists decided if the patient is candidate to surgery, the patient have to go to surgery, and ideally we have to treat the patients with adjuvant capecitabine after the results of the BILCAP trial. This is not ideal, this adjuvant treatment, but it is the only randomized phase 3 positive trial. And then if the patient is not candidate for surgery, ideally the patient is candidate to systemic therapy. Today the standard treatment, and we will review it later, is the combination of durvalumab, gemcitabine, and cisplatin. This is the standard of care in those countries in which durvalumab is approved. But if the patient presented a poor performance status and we cannot give cisplatin and gemcitabine alone is a good option for patients with ECOG performance status 2. What happened in second line, if the patient presented no targetable alterations, we can treat the patient with chemotherapy, changing to 5-FU-based chemotherapy. But if the patient presented a targetable alteration, the second line recommended in the majority of the guidelines are targetable alteration, target therapy, and we will review it later. So, from this publication in 2010, the results of the trial ABC02 trial, in which it was demonstrated that the combination of gemcitabine and cisplatin was superior to gemcitabine with a median overall survival of 11.7 months. It was the standard of care from 2010 to 2022. So in 12 years, we didn't have any positive phase 3 trial in first line in biliary tract cancer patients. However, in 2022, it was published this single arm, different arms but not randomized phase 2 trial that it was done only in one institution in Korea, and in which they tested different strategies with chemotherapy plus immunotherapy in biliary tract cancer patients demonstrated the synergistic effect of the chemotherapy plus immunotherapy, because monotherapy in monotherapy in biliary tract cancer patients demonstrated a modest overall response rate. Here you can see how the chemotherapy plus durvalumab or the chemotherapy plus tremelimumab in first-line setting in biliary tract cancer patients achieved this response rate of 66% or 68%. So really promising results, and with this it was designed the phase 3 trial that changed the standard first-line treatment in biliary tract cancer patients, the TOPAZ-1 trial. This is an international phase 3 trial that includes patients with biliary tract cancer without pulmonary tumors, non-previously treated, so first-line treatment, and the patients were randomized, nearly 700 patients, to be treated with durvalumab plus gemcitabine and cisplatin or placebo gemcitabine and cisplatin. Patients were treated only with 6 months of chemotherapy and then continued with durvalumab or placebo. And this was a strategy of the ABC-02 trial, to stop the chemotherapy after 6 months. Primary endpoint, overall survival. As you can see here, this is the primary endpoint of the trial. The trial is positive for its primary endpoint overall survival with a hazard ratio of 0.80. And you can see here that this is the typical curve of immunotherapy. At the beginning of the curves are completely together, and then from 6 months and from the rest of the curves, the overall survival curves are separately every time more and more. So you can see that the differences in overall survival, in 1 year overall survival rate is less than 10%, 54% compared with 48%, but at 2 years it's more than 10%, 24.9% compared with 10%. So here it's important that 1 out of 4 is alive at 2 years. That's important, this Q of the curve. When we try to see which are the patients that benefit more from the monotherapy, all patients benefit independently of their race, Asian versus non-Asian, the primary location, maybe the hazard ratio, it's more favorable in patients with cholangiocarcinoma than in patients with gallbladder, but all of tumor locations presented a hazard ratio below 1. And finally, PD-L1 expression, it's not important for the efficacy of durvalumab in biliary tract cancer. So please don't use the tissue of the patient determine PD-L1, because this is not useful in this disease. And then also the trial is positive in the rest of efficacy endpoints, so this gives consistency to the results of the overall survival with a hazard ratio of 0.75 for PFS. Again, at month 4, the curves started to be separated and maintained this separation all over the curve. And then overall response rate, it was superior in the experimental arm, 26.7% with 2.1% complete responses compared with 18.7%. Regarding side effects, majority of grade 3 and 4 adverse events were related with chemotherapy, so mainly hematological toxicity. And when you see the immune-related adverse events, these are more frequent in the immunotherapy arm, but grade 3 and 4 only 2.4%. So it's a very well tolerated schedule. When we see, I think, one of important issues, because this is a very palliative population, advanced biliary tract cancer patients, so the quality of life of these patients is so important. And when you see here, when we add durvalumab to the standard treatment, we add efficacy, of course, but we didn't decrease the quality of life of the patient, as you can see here, because the time to deterioration of the quality of life is longer in patients treated with durvalumab compared with those patients treated with placebo. I think this is an important point. Also, we have the first publication this year in 2023 related the real-world data of the combination of gemcitabine and durvalumab, in this case in the Italian population, and that's important because you know when you see the data you don't know exactly what happened in the different population. And here you can see that 145 biliary tract cancer patients from 17 Italian centers were treated with a combination of gemcitabine, cisplatin and durvalumab, and the results were pretty similar to the results reported in the TOPAZ TOPAZ-1 trial with PFS of 8.9 months, median overall survival of 12.9 months, and overall response rate of 34.5%. So completely the same activity done in the TOPAZ-1 trial. Also regarding the side effects, you can see here the grade 3 and 4 immune-related adverse events, only 2.1%. So really the toxicity profile is as good as the TOPAZ-1 trial. But also this year in the ACCR meeting, it was presented and at the same time published the results of the Keynote 966 trial, a trial that confirmed the benefit of immunotherapy in first-line biliary tract cancer patients. Patients in first-line biliary tract, advanced biliary tract cancer patients were randomized to be treated to pembrolizumab, gemcitabine and cisplatin or placebo, gemcitabine and cisplatin. Take into consideration that here patients were treated stop only cisplatin at 6 months, but continued with gemcitabine and pembrolizumab. And the primary endpoint, again, overall survival. This is also a positive trial, has a ratio for overall survival 0.83, and as you can see here, the curves are different. Here, the curves separate from the beginning to month, and then it maintains this separation, but you cannot see this huge difference or long-term benefit. Again, when you see the different subtypes, there's no difference in the different groups, and again, PD-L1 is not useful for pembrolizumab in biliary tract cancer patients. However, in this trial, there's no difference in progression-free survival between both arms with a hazard ratio of 0.86, and there is no difference in overall response rate between both arms, with the response rate maybe higher than expected, 29% in both arms, but with no differences. So here you have the comparison. We cannot do this to compare two trials, but of course we do it. It's inevitable. So first of all, population, very similar population. Asian population, approximately half of the patients. Majority of patients intrahepatic cholangiocarcinoma. Similar overall survival, but difference in PFS, overall response rate in TOPAZ-1. No difference in PFS and in response rate in the Keynote 966. Both trials consistently demonstrated the efficacy of immunotherapy in combination with chemotherapy in first-line biliary tract cancer patients. And with this, what happened with the guidelines? As you can see here, the European guidelines include, in the version that was published in 2022, the recommendation to treat the patient with cisplatin, gemcitabine plus or not durvalumab in first line. This is because not in all countries is approved durvalumab, and this is the reason why it's not in all patients. But then we have the NCCN guidelines, in which you can see that in the United States, in which is approved durvalumab, it's the new standard of care in all biliary tract cancer patients. They recommend as a preferable regimen durvalumab plus gemcitabine plus cisplatin. What's next? What's the next step in immunotherapy in biliary tract cancer patients? First of all, to treat or to try the immunotherapy in the adjuvant setting. This is the Artemide biliary tract trial, in which patients with resected biliary tract cancer patients are randomized to be treated to chemotherapy with investigator choice plus anti-immunotherapy. This is a new molecule of AstraZeneca, is anti-TIGIT plus chemotherapy or chemotherapy alone. And this is a phase 3 trial and is ready to start in a few months. And also interestingly is this trial, Tourmaline trial, in which we try to test the strategy of chemotherapy plus immunotherapy, durvalumab, but in different combinations. For example, in this case, it's not gemcitabine and cisplatin, and we try with different gem-based chemotherapies. For example, gem-cis-baticoc-2, gem-carboplatin, gem-oxaliplatin, gem-S1, gem-cisplatin plus S1, or gem-cis plus nab-paclitaxel. And the objective is to demonstrate that even if you use a different chemotherapy backbone, durvalumab is useful in this population. Let's move now to second line. It is recommended in the ESMO guidelines to do NGS analysis in all those patients with biliary tract cancer tumors at diagnosis before the first line and receive the results during the first line in order to prepare the second line. If a patient presented a targetable alteration, that is approximately half of our patients, those patients have to be treated with target therapies. Here in this slide, you can see the majority of patients, or the most common targetable alterations in intrahepatic cholangiocarcinoma are IDH1 mutations, FGFR2 fusions, HER2 amplification, BRAF mutations, among others. We start now with IDH1 mutation as a target. We have only randomized phase 3 clinical trial in this target treatment in biliary cancer patient, and is the Clarity trial. Patients with IDH1 mutations and intrahepatic cholangiocarcinoma after 1 or 2 lines of treatment were randomized to be treated to ivosidenib, an IDH1 inhibitor, or placebo. And crossover was allowed, so patients that progressed to placebo can be treated with ivosidenib. For this reason, the primary endpoint was PFS. As you can see here, this is a positive trial with a hazard ratio of 0.37. At the beginning of the curves, the first 2 months, there are some patients that progress, but then the patients that didn't progress at 2 months benefit a lot from the ivosidenib treatment. The median PFS is 2.7 months compared with 1.5 months. However, because 70% of the patients did the crossover from the placebo to the ivosidenib arm, it was not possible to demonstrate a statistically significant difference in overall survival, as you can see here. What's next in IDH1 as a target in biliary tract cancer patients? So one strategy is this trial, that is the PROVIDE trial, that is a confirmatory phase 3b study with the activity of ivosidenib in second or third line biliary cholangiocarcinoma patients with IDH1 mutations, and the primary objective is to demonstrated that there's events of these treatment and also the efficacy parameters. And also another strategy, it is not so clear how sensitive is IDH1 mutated biliary tract cancer tumors to immunotherapy, because there are some publications that suggest that those tumors are more cold than those with other molecular alterations. For this reason, one strategy is to give together the ivosidenib plus immunotherapy. One trial that is ongoing is this single-arm phase 2 trial that combine ivosidenib plus nivolumab in second line or beyond lines with patients with IDH1 mutations. And let's change now to the FGFR as a target. Different single arms phase 2 trial demonstrated the activity of different FGFR inhibitors in patients with FGFR2 fusions in biliary tract cancer. This is especially common in patients with intrahepatic cholangiocarcinoma, around 10% of patients, and here you can see different drugs. Only approved is pemigatinib and futibatinib. These are the only FGFR inhibitors approved for those patients with FGFR2 fusions. As you can see here, this was the first drug, pemigatinib, that is FGFR1, 2, 3, and 4 inhibitor that was approved in United States, but also in Europe. And here in this trial, that it was the 5202 trial, patients with cholangiocarcinoma and FGFR2 fusions were treated in one cohort, that is the first cohort, but then also this pemigatinib treatment was tested in different cohorts, in other cohorts with other FGFR alterations or with no FGFR alterations. And the primary endpoint was overall response rate. In that trial, it was demonstrated the activity of those of pemigatinib in those patients with FGFR2 fusions. Overall response rate of 35.5% is superior than the response rate demonstrated with gemcitabine and cisplatin in first line, also with gem, cis, durva in first line. So really it's a promising activity with median duration of response of 7.5 months and a PFS of 6.9 months, overall survival 21.1 months, and this is a refractory population. However, pemigatinib didn't demonstrate activity in those patients with other FGFR alterations or with no FGFR alterations, only in those patients with FGFR2 fusions. And then we have the new generation of FGFR2 inhibitors. This drug, Relay 4008, is a highly selected irreversible FGFR2 inhibitor. And this is, there's a phase 1b clinical trial, that is a refocus trial, in which patients with cholangiocarcinoma are treated with this drug in different situations. One, patients with FGFR2 fusions and FGFR naive, or patients refractory to previous FGFR inhibitors, or patients with FGFR mutations. And these results were presented in the last ASCO meeting. As you can see here, it's only few number of patients, so preliminary results, but in those patients that were treated with FGFR fusions, FGFR naive, at the recommended dose, that is 70 milligrams per day, the overall response rate is 73%. So that's much higher than what it was demonstrated in the rest of therapies in this disease. And when you see in those patients previously treated with other FGFR inhibitors, for example, previously treated with pemigatinib or with futibatinib, the overall response rate at the recommended dose, it was 21%. So pretty much activity, or the same activity that it was demonstrated in first line with gemcitabine and cisplatin with the ABC02 trial. So even in those patients previously treated with other FGFR inhibitor, the activity is pretty high. And also interestingly, because we don't have much treatments in this situation, this drug demonstrated activity in those patients with cholangiocarcinoma and FGFR2 mutation, not fusion but mutation. And in this case, the overall response rate was 29%. I think, again, it's pretty active drug in this population in which we do not have any really active treatment. And also interestingly, it's what's next in FGFR inhibitor. This is probably one drug that is this tinegotinib, that is a tyrosine kinase inhibitor that probably will allow us to do a sequence strategy. This drug demonstrated in a phase 2 trial pretty high activity in those patients previously treated and that progressed to FGFR inhibitors. As you can see here, these patients with this red or pink color and yellow color, those are patients treated with this drug, previously treated with FGFR inhibitor that progressed, and then here you have the duration of response, and you can see that some patients were treated with during 8 or 9 months. So that's really something promising, and in fact a randomized phase 2 trial in second line after in second line or beyond, so after FGFR inhibitor it's designed in order to test this drug versus standard of care. And also, this is the trial, first 308. It's a trial with objective progression-free survival, and it's patients with cholangiocarcinoma, FGFR2 fusions that progress to other FGFR inhibitors approved by FDA, so pemigatinib or futibatinib, are randomized to be treated with oral tinegotinib versus investigator choice of chemotherapy, so FOLFOX or FOLFIRI. Well, let's see if this trial established the new sequential strategy in the patients with cholangiocarcinoma and FGFR2 fusions. And also, next step in FGFR inhibition is to demonstrate the activity of those drugs in first-line setting. This is the only trial that survived because initially we had 3 phase 3 clinical trials with pemigatinib, infigratinib, and futibatinib. Futibatinib trial and infigratinib trial closed due to the slow recruitment, and we have today the trial with pemigatinib. Patients with FGFR2 fusions at first-line setting are randomized to be treated with gemcitabine cisplatin compared with the FGFR inhibitor, so pemigatinib, and the crossover is allowed, so the primary objective is progression-free survival. This trial is very difficult to recruit, so we will see what happens in the near future. And now let's change the target, and let's change in the very interesting target that is HER2. It's interesting because it's frequent, especially in gallbladder or in extrahepatic cholangiocarcinoma, and less frequent in intrahepatic cholangiocarcinoma. And I think this is interesting because in gallbladder we don't have much more targetable alterations, only this and some others, but it's less common to find a targetable alteration compared with intrahepatic cholangiocarcinoma. This ASCO meeting, and at the same time it was published, the results of this trial, a single-arm phase 2 trial with zanidatamab, that is a bispecific antibody with against HER2, and test this drug in monotherapy in patients with HER2 amplification and biliary tract cancer in second line or beyond, so really pretreated population. Objective overall response rate of those patients with immunohistochemistry 2+ or 3+. And you can see here the results, and the overall response rate was more than 40%, 41.3%, median duration of response 12.9 months, this is 1 year responding, and PFS 5.5. So really this is interesting data. And also it was presented in the last ASCO meeting, the combination of tucatinib, an oral tyrosine kinase inhibitor, plus trastuzumab in patients previously treated HER2 positive with overexpression or amplification of biliary tract cancer. This is a phase 2 basket trial, and one of the cohorts of this basket trial was or include patients with biliary tract cancer, and they include 30 patients. The overall response rate was 46.7%. So again, a really active strategy. And finally, we have trastuzumab deruxtecan, that is an ADC that you know very well for the breast cancer and also for gastric cancer, but also demonstrated some activity in biliary tract cancer. As you can see here in the Destiny PanTumor02, they tested this trastuzumab deruxtecan in patients with HER2 expression in different cancers, and you can see here that when they test biliary tract cancer patients, they demonstrated a high activity, especially in those patients with immunohistochemistry 3+, with a response rate of 56.3%. So really, this is a high activity in this population. Also, another important target, it's not so frequent, 5-7% of patients with biliary tract cancer patients, is the BRAF V600E mutations, and the combination of the dabrafenib plus trametinib demonstrated in the ROAR trial in the cohort of patients with biliary tract cancer tumors a response rate around 50%. You can see this forest plot in which the majority of patients responds to the treatment, and the tolerability of this combination is pretty safe. So that's a very good option for the patients with these BRAF V600E mutations. The duration of response is 9 months, the overall survival 14 months in this really pretreated population. What's next in biliary tract cancer? So we have new targets coming, for example, the MDM2 amplification. So the Brightline 2 clinical trial is a single-arm phase 2 trial in which patients with biliary tract cancer and also tumor types with MDM2 amplification and TP53 wild type are treated with this drug from Boehringer 1978-8. This drug blocks the link between P53 and MDM2, and with this block, of course, the progression of the disease. And so MDM2 amplification is especially frequent, again, in gallbladder and extrahepatic cholangiocarcinoma, more frequent than in intrahepatic cholangiocarcinoma. So we will see, we have preliminary data of a phase 1 trial, only this small number of patients, 10 patients, but you can see here in this strategy with this drug or this drug in combination with immunotherapy, and you can see here the response rate is pretty high and pretty promising in this group of patients with this specific amplification. So important, when you have a patient, you can have this NGS analysis and be sure that this NGS panel include also the detection of MDM2 amplification. So in conclusion, biliary tract cancer, as I mentioned, is an heterogeneous group of patients. Cisplatin and gemcitabine remains a standard of care plus immunotherapy, of course, durvalumab, that's important. And today, the standard change in those countries in which durvalumab is approved. Gallbladder presented an opportunity for targetable alterations, being HER2 amplification and BRAF V600E mutation the most promising, and then intrahepatic cholangiocarcinoma, of course, presented the higher incidence of targetable alterations with FGFR2 fusions, IDH1 mutations, HER2 amplifications, and BRAF V600E mutations. TOPAZ-1, as we mentioned, randomized phase 2 trial that demonstrated the survival advantage with a combination of gemcitabine, cisplatin, and durvalumab, and established a new standard in biliary tract cancer patients. and the keynote is a randomized phase 2 trial that demonstrated a survival advantage with a combination of GEM-CIS Pembro and confirms the efficacy of immunotherapy in first-line biliary tract cancer patients in combination with immunotherapy. Of course, it is crucial to have an NGS analysis in those patients with biliary tract cancer tumors at the beginning of the disease, so at diagnosis ideally, in order to treat our patients with target therapy if they presented these targetable alterations. And with this, I want to thank you for your attention, and you have here my email if you have any doubts. Thank you again.
Thank you, Professor Teresa, for a very updated presentation. And we can have the chance to open the floor for a couple of questions because we have you with us online. She's live. She's online, huh? Recorded? Okay, thank you.
Good morning, everybody. So the second talk will be presented by Professor Osama Al-Dali, which will be on sequencing treatment in metastatic pancreatic cancer within 25 minutes.
Bismillahirrahmanirrahim. Thank you, Mr. Chairman, for this nice introduction. Sure, I'd like to congratulate our colleagues in Ain Shams University for this successful conference and give me the opportunity to discuss sequencing treatment in metastatic pancreatic cancer. So, all of us know that tumor location has an impact on symptoms and tumor resectability. Nearby location of major veins and arteries impact tumor resectability and thereby treatment options. We have about 60 to 70% located in head of pancreas and linked to jaundice, and another part of 20 to 25% located in body and tail of pancreas and linked to epigastric pain. So nearby location of major veins and arteries impact tumor resectability and thereby treatment options. And about more than 80% of our patients with pancreatic cancer treated at diagnosis presented as advanced stage, either locally advanced or metastatic disease. It is a global issue that we have by the year of 2014, more than about 355 cases, 355,000 cases, new cases in 2014. And while the pancreatic cancer is a relatively rare disease, but unfortunately with high mortality. So we have a poor prognosis. We talk about a disease, median overall survival typically below 12 months, and when metastatic, we can go for median overall survival 2 to 6 months, and 11.5% median 5-year survival. and about more than 80% of patients presented with advanced disease. So pancreatic cancer is one of the worst possible diagnoses due to poor prognosis. Unlike other cancers, there have been almost no improvement in pancreatic cancer survival rates, and the 5-year survival confirmed pancreatic cancer remain one of the most aggressive cancers, and thus we tell about disease of a lot of unmet needs. The huge improvement in survival for many cancers over the last few decades, but unfortunately not for pancreatic cancer, and the 5-year overall survival less than 10%. The prognosis is very poor, more than 80% of our cases is advanced, and the median overall survival below 1 year, and the median 5-year survival about 3% only. The high expected increase of the pancreatic cancer cases from 2020 to 2040 make it maybe the second cause of lethal of death due to cancer in 2030, and the drug development have been challenging in pancreatic cancer, but they have the lowest clinical trial success and rate in oncology with about 30% only. So we can summarize this. We have a disease, the median age about 71, more than 80% of our cases are advanced. The incidence increase with age, and with median overall survival below 12 months, and have a relatively low incidence but high mortality, and predicted to be the second cause of death by 2013. The year of 2013, and many patients have recurrent disease following initial treatment, and we have a limited number of approved treatment, about only 6 protocols. So why is pancreatic cancer so difficult to treat? The pancreatic cancer is not a conventional disease. Challenging pancreatic tumor biology result in efficient drug delivery and inadequate tumor response. So we have a dense stroma rare, immunosuppressive tumor macrophage, low microvascular density, and leaky vasculatures. We have a dismal prognosis. I tell you that we have survival about 0% in locally advanced, unresectable, and metastatic disease. So we treat a very dismal prognosis. What is our challenging disease? Unique anatomical location, difficult surgery, post-operative complication, high recurrence rate, local complication, pain, intestinal obstruction, and for sure obstructive jaundice. We deal with a rapid progressive disease and lack of effective treatment despite many trials. Unfortunately, many of failed trials. Now we talk about the first line treatment. We should give factors affecting our decision making by patient-related factors like age, performance status, comorbidities, patient preference, tumor-related factors such as disease burden, symptoms, CA19 line level, molecular print. What is our objective? To improve survival and to improve quality of life of our patient, and the others like treatment availability. Please don't forget that we should control of pain, nutrition support, stent for obstruction, and psychological support for reassurance. The story started with gemcitabine, the first drug to be tested versus 5-FU, with very good results as regard good BFS and good survival, but unfortunately this is about 5 months overall survival. And gemcitabine becomes the standard of care, either alone or in combination. By the addition of erlotinib, we reach overall survival about 6 months. And we notice that a patient will benefit from addition of erlotinib, either EGFR positive or EGFR negative. By the addition of S1 to gemcitabine, nearly we have no benefit in overall survival. Till the addition of FOLFIRINOX in the famous trial, FOLFIRINOX versus gemcitabine, we reach progression-free survival 6 months and overall survival about 11 months. In the subgroup analysis, we have tremendous side effects, more in the FOLFIRINOX arm, but still all subgroup will benefit from FOLFIRINOX. Due to side effect, we challenge the same for modified FOLFIRINOX to can afford the side effects. By introduction of nab-paclitaxel to gemcitabine, we reach about survival about 8 months. So, before the era of gemcitabine, nothing to work. When we use gemcitabine, we achieve survival about 5 months. By the addition of erlotinib, we reach the 6 months overall survival. By using FOLFIRINOX, about 11 months overall survival. By the addition of nab-paclitaxel to gemcitabine, we reach about 8 months overall survival. So, for sure, the cross-trial comparison should be interpreted with caution due to difference in the study population, and we not compare the study, but just mention the net result of each study. So the chance from the history that we have mostly 3 regimens: FOLFIRINOX, gemcitabine, and nab-paclitaxel plus gemcitabine as a first-line treatment. And the liposomal irinotecan plus 5-FU was received as a second line after progression on gemcitabine. So the Napoli 3 study tried to confirm that we can use NALIRIFOX for first-line treatment. This is the population. You notice that we use FOLFIRINOX, but with the exception of by using liposomal doxorubicin instead of liposomal irinotecan instead of irinotecan, and the another arm gemcitabine plus nab-paclitaxel, and this is the result. There is overall survival about 11 months also, and all subgroup will benefit from our combination. Progression-free survival is still, we have a very good BFS, and all subgroup will benefit from our protocol, and the tumor response more or less the same in between the comparison of 2 arms of the study, and the overall safety can be manageable. And when we talk about the side effects, and the gemcitabine nab-paclitaxel arm, we have more anemia, thrombocytopenia, and pyrexia, while in the NALIRIFOX arm, we have more diarrhea, nausea, vomiting, and hypokalemia. So we can conclude that NALIRIFOX improve overall survival and the progression-free survival in various patient subgroups, and the side effects were manageable, and the investigator concluded that this support we can use NALIRIFOX as a new reference for first-line regimen for metastatic pancreatic cancer. After the first line can we go for maintenance or keep the patient under follow-up? There's a Apollo trial with maintenance olaparib versus placebo after first-line platinum-based chemotherapy, and we have progression-free survival and BFS2 benefit, but unfortunately we have no overall survival. What about using chemotherapy in maintenance treatment? We have 3 arms, 12 cycles of FOLFIRINOX. Arm B, FOLFIRINOX 8 cycles followed by 5-FU. And Arm C, sequential treatment with FOLFIRI and gemcitabine. And the result was that the patient have a good quality of life in this period of maintenance treatment. So, if the patient is progressed after first line of treatment, go for second line. We have factors affecting decision-making in second line. What is the first line you use? What is the performance status? What's the comorbidities, goals of treatment, patient preference, and the drug availability? Please be sure that early initiation of palliative care services improve clinical and the quality of care outcome and may prolong survival. So we have many options in second line: oxaliplatin plus either capecitabine, S1, gemcitabine, irinotecan, modified FOLFIRINOX, paclitaxel, nab-paclitaxel, gemcitabine, 5-FU, S1, irinotecan, or FOLFIRI. The second line oxaliplatin-based regimens achieve overall survival and progression-free survival. Unfortunately, this trial by using the modified FOLFOX 6, this is was inferior to using 5-FU. And now the question why we think of liposomal form of drugs, not a conventional form in pancreatic cancer. We can repeat our slide that pancreatic cancer is not a conventional disease, and inefficient drug delivery and rapid clearance of the drug from circulation and inadequate tumor exposure to our drug. So we have a NAPOLI trial by using liposomal irinotecan alone or 5-FU alone or combination between liposomal irinotecan and 5-FU, and this is the result. The overall response is about 60.2% objective response rate, and the tumor marker, and there is decrease in tumor marker CA19-9. Progression-free survival and overall survival with significant difference, about 2 months in both, in between two groups. And this is achieved in real-world evidence studies, either Australian, Korean, Italian, Japanese. There is a progression-free survival and overall survival benefit on all those trials. So, if the patient is progressed upon second line of treatment, can we go for third line of treatment? Unfortunately, most our patients considered unsuitable due to poor nutritional status and poor performance status after the first and second line of treatment, and no standard regimen can be recommended. And most our patients go for best supportive care, unless if the patient have good BS, we can put the patient in a clinical trial. What about the future and the current advances? We can use hyaluronic acid, platinum compounds, and PARP inhibitor, BRCA positive, and in some selected cases, we can use immunotherapy. Don't forget the palliative treatment, obstructive jaundice, duodenal obstruction, pain, and malnutrition. And this is the landscape for metastatic pancreatic cancer. We have about 20% of our patients will be relapse or progression within 6 months of adjuvant therapy. You can go for modified FOLFIRINOX and second line GEM nab-paclitaxel, or go for GEM-based chemo. If you go for GEM-based chemotherapy, in the second line you can go for modified FOLFIRINOX or liposomal irino plus 5-FU, or oxaliplatin 5-FU or FOLFOX, and in third line oxaliplatin 5-FU or Naliri. In another part of our patient, about 70% metastatic de novo, we should go for performance status. If performance status 3, best supportive care. If performance status 2, go for GEM nab-paclitaxel. Performance status 1, we can go for modified FOLFIRINOX, and second line is the same. And in about 10% of our patients, if there's a BRCA mutation, we go for platinum-based chemotherapy followed by PARP inhibitor, and in very selected cases, we can go for immunotherapy. So our recommendation in treatment of metastatic cancer pancreas is a lethal disease with an aggressive biology and poor overall survival. It is very challenging, maybe due to anatomical location and the high stromal density. No dramatic improvement of survival through the last 15 years. Despite many tested agents, we have many failed trials. Modified FOLFIRINOX, gemcitabine plus nab-paclitaxel, or single agent Gemzar are the standard first line treatment. The area of maintenance treatment is attractive but needs further research and not a standard of care yet. The decision for second line is so difficult. Rapidly growing disease with rapid deterioration of his general condition, lack of really active agent, and lack of phase 3 trials. Most patients are considered unsuitable for third line chemotherapy. Liposomal irinotecan plus 5-FU or FOLFOX, FOLFIRI, gemcitabine can be used as a second line. BRCA mutation and another mutation maybe help us in the choice of our considered targeting treatment. So metastatic cancer pancreas is still an area of unmet need and need a lot of research, and thank you for your attention.
Thank you, Dr. Osama, for your very nice, informative presentation. Floor is open for questions. Dr. Assam Bey.
Thank you, Professor Osama, for this session. Can I ask you about the combination of local advanced cancer-hit pancreas of radiation and combination chemotherapy may add benefit unresectable to be resectable disease?
For sure. كان هو الموضوع النهارده عن الميتاستاتيك بانكرياتيك كانسر. You ask about locally advanced cancer pancreas. We have many options. Option of neoadjuvant chemotherapy followed by radiotherapy, neoadjuvant concurrent chemoradiotherapy. More or less about 80% of our patients not to be resectable after neoadjuvant treatment. And from literatures, most patients either operable or inoperable from the start. And when you when you use either chemotherapy, concurrent chemotherapy, or another lines of treatment as neoadjuvant, we don't achieve marvelous response to be an operable patient except in very selected cases. But it's approved, you can use concurrent chemotherapy in the neoadjuvant area.
Any other question? I have one question for you. For those starting with Nalirifox, for how long they will go on treatment? Or it will be stopped and go for duration of treatment in Nalirifox. Do you stop upon improvement of symptoms? Is it until progression? Or you will maintain on infusional fluoro only?
It's a very nice question. We have Nalirifox in the second line. If the patient have a good BS, we can continue treatment in the second line unless the patient have no side effects and have a good performance status. We can go forward till disease progression. The study, I think, approves this, and this is about 6 months of overall survival, and we have 3 months progression-free survival.
Thank you. Any other question? Is Dr. Therese available or still not available? Not available. So by this, we can close our session. I would like to thank all of you for attendance, and I'd like to thank Coach.